This global data map shows that across the adult population, chronic pain maintains a staggering and persistent prevalence of 22%. For decades, medical consensus treated this massive clinical burden as a single, uniform symptom, a simple, prolonged reflection of ongoing damage in the body's peripheral tissues. That perspective drove a reliance on broad-spectrum pharmacological suppression. Physicians deployed opioids to numb the sensation rather than identifying and treating underlying mechanisms. Current neurobiological research has dismantled that approach. Chronic pain is now classified as a highly heterogeneous syndrome and a standalone disease state in its own right. This chart divides chronic pain into three primary subtypes. Nociceptive pain originates from actual tissue damage. Neuropathic pain, arising from nervous system damage, affects 7 to 10% globally. Nociplastic pain, marked by altered central processing without clear injury, affects 5 to 15%. To implement effective precision medicine, we have to map the exact molecular transition that turns a protective biological alarm into a maladaptive neural disease. The sensation of acute pain begins with transduction. Lightly myelinated A delta fibers rapidly transmit sharp, localized signals of immediate danger, while unmyelinated C fibers convey the slower, sustained aching that follows. This protective system is activated by environmental triggers, such as extreme physical trauma or the direct tissue disruption of a surgical incision. Damaged cells and responding immune units flood the local area with an inflammatory soup, releasing protons, bradykinin, nerve growth factor, and cytokines like TNF-alpha. These biochemical mediators bind to specific receptors on the nerve terminals, particularly the transient receptor potential vanilloid 1, or TRPV1, channel. This binding lowers the receptor's activation threshold. What would normally be a harmless thermal or mechanical stimulus now triggers a rapid electrical discharge. The nociceptor undergoes a complete phenotypic switch. It begins firing spontaneous ectopic action potentials and exhibits primary hyperalgesia, becoming hypersensitive to any further input. This localized peripheral sensitization acts as the initial amplifier. It generates the relentless, high-intensity sensory barrage required to force permanent structural changes further up the neural pathway. This schematic traces that sustained peripheral pain signal up the ascending axis, terminating in rexid laminae 1 and 2 within the spinal cord's dorsal horn. Here, the hyperactive first-order neurons dump excessive amounts of glutamate and pro-nociceptive neural peptides, such as substance P, into the synaptic cleft. This intense chemical barrage forces a crucial postsynaptic event. The activity-dependent signaling dislodges the magnesium ion blocking the NMDA receptor, allowing a massive influx of calcium ions to surge into the second-order neuron. The elevated intracellular calcium acts as a powerful second messenger, triggering complex kinase cascades. These kinases phosphorylate ion channels and drive enhanced synaptic trafficking, pulling more AMPA receptors to the cell membrane, permanently increasing the synapse's strength. Clinically, this molecular reorganization manifests as tactile allodynia. Normal subthreshold inputs from A-beta mechanoreceptors, like the light touch of a shirt, now trigger pain circuits. Simultaneously, the spinal cord loses its regulatory brakes. GABAergic and glycinergic interneurons experience functional impairment, heavily reducing the system's inhibitory tone. This combination of amplified excitation and diminished inhibition defines central sensitization. It is the specific synaptic plasticity that converts a transient sensory alarm into an autonomous, chronic disease. Once central sensitization is established, the pathology diverges into two distinct pathways, one driven by structural damage, the other by functional dysregulation. Neuropathic pain occurs when there is a physical lesion or disease directly affecting the somatosensory nervous system, such as a severed nerve or metabolic degradation from diabetes. The injured axons attempt to compensate by pathologically upregulating voltage-gated sodium channels, particularly NaV1.3 and NaV1.7. This structural defect causes the nerve to fire self-sustaining ectopic discharges indefinitely. Nociplastic pain, conversely, involves a central sensitization that is maintained entirely without discrete structural nerve damage or ongoing peripheral tissue injury. Instead of damaged neurons, this state is driven by a functional neuroimmune glial axis. Astrocytes and microglia enter a hyperactive pro-inflammatory state. They continuously release signaling molecules like interleukin-1 beta and TNF-alpha, which directly foster long-term potentiation of the pain synapses. This glial activation is paired with a severe dysregulation of the descending inhibitory pathways from the periaqueductal gray to the locus ceruleus. The brain's natural ability to suppress pain transmission is dismantled. Effective treatment hinges on making this exact distinction. Clinicians must identify whether the pathological engine is a physically broken nerve continuously firing or a structurally intact nervous system hijacked by its own immune cells. This biopsychosocial model maps how the transition to a chronic state is dictated by a broader architecture modulating the patient's physiology. Intrinsic vulnerabilities, such as genetic polymorphisms in HLA alleles or OPRM1, can pre-wire a patient's neuroimmune system for hyperactivity. This genetic predisposition often converges with a severe neuroendocrine paradox. Patients frequently exhibit hypoactivation of the hypothalamic pituitary adrenal, or HPA, axis. This blunts cortisol production, stripping the body of its primary anti-inflammatory control. Concurrently, the sympatho-adreno-medullary, or SAM, axis becomes hyperactive. It floods the system with catecholamines, accelerating central sensitization and elevating nerve excitability. Extrinsic factors actively dictate these hormonal imbalances. Early life psychological trauma and poor sleep architecture act as potent environmental stressors that can permanently dysregulate these exact neuroendocrine feedback loops. Correcting the systemic neuroendocrine environment is a prerequisite for reversal. Targeting the spinal level alone fails to address the underlying permissive pathology. Because the pathophysiological roots of chronic pain vary entirely by subtype, this diagnostic matrix is required to filter subjective symptoms through rigorous objective clinical frameworks. Nociceptive pain is typically evaluated using the McGill Pain Questionnaire, which isolates clear peripheral drivers and evaluates localized tissue damage. Neuropathic pain requires tools like the DN4. This isolates the specific neurophysiological screening necessary to detect ectopic symptom descriptors, such as burning sensations or electric shocks. Nociplastic pain relies on the central sensitization inventory to capture the widespread hyperalgesia and mood dysregulation characteristic of a condition lacking discrete structural biomarkers. This diagnostic mapping explains the widespread historical failure of conventional analgesics. NSAIDs and opioids act on peripheral inflammation and nociceptive transmission. They do nothing to reverse glial activation or restore descending inhibition in neuropathic or nociplastic patients. The modern clinical standard requires targeted multimodal strategies, implementing emerging technologies like cold atmospheric plasma, which are designed to directly modulate these specific neurobiological pathways. Broad-spectrum pharmacological suppression is obsolete. True clinical efficacy demands precision medicine that targets and dismantles the specific biological, psychological, and social drivers sustaining central sensitization.